welcome. We're going to start in a couple of minutes. We're just waiting for more people to arrive. In the meantime, you have access to the chat box, so you can all introduce yourselves. It would be nice if you told everybody where you're from, if you have any organizational affiliation, or where you're based. It's always nice to know where people are coming from. And yes, we'll start in a couple of minutes. Let more people arrive. We have 28 participants for the moment. We are expecting about 90 in total, I believe. So let's give it a couple more minutes. We just had Annabel arrive, who's also one of the speakers. Hello, Annabel. We're waiting for a few more people to arrive before we start, just so that you know. You can introduce yourselves in the chat box in the meantime.
Hello.
Hello, Annabel. Hi.
Hiya. Hi. Just to let you know, I think Edem's not going to be joining us this evening.
Okay, that's good to know. I was wondering that actually. We're still waiting for a few more people to arrive before we start officially.
Okay, yeah, no problem.
But yeah, thank you for letting me know. Okay, I think we should start. And if other people arrive in the meantime, that's great. I can see that people have started introducing themselves. That's great. So welcome to the third webinar in the Feminist Library Care series. Before we've talked about the impact on the pandemic on care workers and women more generally. Tonight we're going to be focusing on reproductive health care as care too, because I believe that's a very rarely recognized area as care. We often recognize it as reproductive rights, but not so much as care. So I would like to talk about it in that context and in the context of the pandemic tonight. Hopefully Zoom will behave. I've had some technical issues today already. I've been kicked out several times, so if I do get kicked out, apologies for that in advance. Gail from the Feminist Library will take over. Also, we have Emma and Sarah from the Feminist Library also supporting tonight. So if you have any technical questions, please direct them to Emma. If you have any questions to speakers, please direct them to Sarah, or you can post them directly in the chat box to everyone as well, and Sarah will pick them up as well. We are recording the webinar, so if you don't want to be recorded but want to ask your question yourself in the discussion part of the session, please let us know. We can pause the recording. Just let us know when you're asking your question so that we and pause it in time for you to come in. We will be collecting contributions and questions all the way throughout, so please keep sending your questions. You don't have to wait all the way until all the speakers have spoken. All the people who are supporting tonight have Feminist Library in their names, so you should be able to find them quite easily. I'm really sorry I don't have video. It's because I'm joining on my laptop, which doesn't recognize that I have a camera on my laptop for some reason. I did want to show you my Black Protest T-shirt tonight because women in Poland were protesting again tonight, and hopefully we're going to talk about it with Paula a bit later because she's also Polish and doing work in this area. So I'm not going to tell you a lot more about that at this point. Please stay muted while we're having the conversation with the speakers. It's going to take, each speaker is going to speak for about 10 minutes. So it's going to take about, we have 6 speakers, so it's going to take about an hour in total. And then we'll have an open questions and answers session. So like I mentioned before, everybody can ask their own question, or you can just raise it in the chat if you don't want to ask it yourself. That's fine as well. Please share any links with us to any other organizations or relevant reports or news information or relevant updates that you would like to share with other people. We will be posting resources on our website. We have a resources section. We will also be sharing them in a follow-up to this session, so the information can reach as far as possible. Okay, and finally, before we go into the actual interesting part of the session, we do need to raise funds for the Feminist Library. We are a very small charity, and we know that most of you have already donated when you came to this session, but if you would like to know how to best support the library, please follow the link that will be posted in the chat to our friends scheme. It's the best way to support the library. It's a way to give a regular donation and keep the library running. So we really appreciate all the friends that we have. Okay, and now to the business of reproductive healthcare. So like I mentioned before, it's a very personal topic to me. I'm Polish, and it has been a very difficult few years for Polish women. We have had major strikes for reproductive rights. As you have probably heard, what you might not have heard is that the attacks that we faced were also on sexual education, on LGBTQ rights, and the right-wing agenda is really spreading in Poland. So in the most recent news, the Polish president has said without much shame that LGBTQ people are ideology, not people. So this has actually been quite popular in the Western media, so it might ring some bells with you, but this is just one of the many examples of the attacks on human rights and freedoms in Poland that we have faced recently. And so I'm very excited for this webinar because it will touch on many of those issues. We will talk about not just access to abortion, but reproductive health care, as well as rights of people of color, access to healthcare, sexual healthcare and education, and contraception. So without further delay, I would like to ask my first speaker to introduce herself. Annabel is the founder of Decolonising, Contraception, And they've been doing a lot of amazing work online during the pandemic. So I'm really excited to hear about that and everything else that's been going on and how the work has been impacted by the pandemic. So Annabel, the floor is yours as soon as you've been unmuted anyway.
Thank you very much, for that introduction, and hi everyone. Thanks for joining this evening. So I've kept it quite informal. In terms of, I'll just give a brief overview of what we've been doing and how we've been affected. So I'm Dr. Annabel Sowemimo. I'm a community sexual reproductive health registrar. I'm based in Leicester, actually. So during the pandemic, I've been doing abortion provision. I've been on the acute gynae wards as part of my redeployment. I've also been doing quite a bit of postpartum contraception work as well. And I founded Decolonising Contraception 2 years ago, and what we are is a collective of Black and people of colour working in sexual reproductive health. So we span lots of different sectors. I'm also a writer and a journalist, and I have a column in Them called Decolonising Healthcare, where I discuss some of the barriers more widely to accessing healthcare. So decolonising contraception is a bit of a misnomer, because we don't just discuss contraception, we discuss all of sexual reproductive health, and in fact we discuss just healthcare generally. But the reason we called it decolonising contraception is because contraception has a bit of a murky history, a murky colonial history, and a bit of a colonial hangover, in that it's been used for population control. People often feel that when medical professionals offer contraception, it's not necessarily with their best interests at heart. And we thought there's a lot of work as well to do around contraception being seen as purely and exclusively just the issue of cis women, and actually some of the demographics that are most affected by kind of forced sterilisation globally are gender non-conforming and queer people. So we that's why decolonising contraception kind of came together to discuss all of those things. In terms of how it's been for the last few weeks, we subscribe to an idea and ethos of reproductive justice. There's been reproductive justice movements in Britain for decades, and we look to like the work of OAD and other groups like that have come before us. The term reproductive justice was kind of coined by women of colour in the US, and it was because they were trying to move away from a choice narrative, which often doesn't really apply very well to some of the situations that people of colour, Black people of colour, find themselves in that choice makes it sound like there is a wide range of options, but due to structural oppression and violence and racism and colonialism and queerphobia and all of these things, sometimes it's not a choice. It means that we can't, because of services, we don't have the resources, and actually we need a much broader approach than the one that a typical kind of reproductive rights approach creates for us. So in terms of decolonising contraception's work, we have organised broadly across 3 strands, which kind of mirrors, I guess, my own interests and what I do, but also I think where we need to do the work to get the results that we need. And there are huge gaps in sexual reproductive health, particularly for Black and people of colour, whether that's HIV access, whether that's lack of contraceptive uptake, whether that's high rates of things like gonorrhea that lead to obviously problems with infertility, late cervical smear screening. There's multiple, and it's usually the same demographics affected. So our strategy is to do academic work, partner with researchers, also uplift some of the researchers in our collective. We do have PhD candidates and stuff in our collective. Also just forming a community, because actually it can be quite a lonely place. A few of us come from groups demographics where talking about sex and sexuality is quite stigmatizing and taboo, and it's been quite important to find a support system now more than ever, with obviously Black Lives Matter and what we've been seeing with the COVID-19 data. And also we do community work, so we're trying to understand why we have these disparities. Our needs have kind of been neglected in a lot of academic work and research up until this point. So with the few resources we have, we've tried to, you know, do focus groups, understand, take it to a higher level and say, actually, there's more to be done here, and as researchers, can you help us kind of take a look at some of this. And with all that in mind, now has been quite a challenging time, obviously, as I mentioned, because there's so much other things that have been going on. So our work's been quite heavily impacted. We were planning the first kind of sexual reproductive health festival for Black and people of colour in April. We had to postpone that. We put in quite a lot of work. We were trying to do things differently and make sexual reproductive health seem less burdensome, cumbersome rather, and less of a burden to the demographics and communities that we're from, and, you know, do something fun. We're going to have that at the Vagina Museum, and we had to kind of put that on hold. So we've been using digital media a lot more, which was our strategy anyway, because we know that a lot of communities that feel stigmatized from face-to-face services have used digital platforms and Facebook groups, Twitter, to combat some of that stigma. And that's why, you know, hashtags have been formed like Me Too and Black Lives Matter by Black women, because we feel safer doing certain and saying some of these things online, and then we can take that into a movement. So we've been doing a lot of digital series, and reproductive justice is also about self-care. So we have a yoga series going on and writing workshops. And kind of to conclude, because I'm not quite sure how much time I have, but I feel like somebody might nudge me if I don't have too much time left. I think this has been a really challenging time in terms of the landscape of reproductive health. Personally, for me, it's hard to talk about like being exhausted, I guess, and a burnout, but those things are real and you have to recognize them. And there's been a lot of things. So from a medical point of view, I was, before Black Lives Matter came to the fore, I was already trying to do a lot of work in terms of talking about the COVID-19 and the disparities that we're seeing, because actually we've seen those disparities in sexual and reproductive health for a while. So, you know, all those conversations about structural oppression and how it affects and causes disparities, we were having those, and then trying to feed that into some people that were less familiar with those conversations, and academics in our circle, including myself, trying to do pieces and academic work around that. In terms of how it's affected Black and people of colour groups more widely, I think that there's been, I can only speak from my personal experience, I think it's been quite overwhelming, because at the beginning of the pandemic, a lot of us felt that maybe, or people felt, and I wrote an article for Galden, that, oh, Black people weren't going to get COVID because Africa was seemingly fine, and the narrative of Africa is that it's under-resourced, and so therefore, you know, people, and there was a lot of myths around that, and then it went to, hold on a minute, all the first 20 people to die of COVID from NHS workers are all non-white people, and then it jumped right into Black Lives Matter. So it's been an overwhelming time, but because we've been sat and had to watch our screens, there's been a lot of change, both within SRH in terms of things that we thought couldn't happen, like telemedicine care, which does suit some people, especially those that are monitored or suffering sometimes intimate partner violence, can't get out of their house. Those changes have come to the fore because there's been an opportunity, and I think that actually, although it's been a very draining time, it's also a really promising time because of how the pandemic has just created so much change and made people focus, and, you know, made us have to adapt. How some of these changes may help the communities that I kind of advocate for in the long run is, you know, something that only time will tell, and we don't have the research to begin with from before the pandemic, so it can be a bit difficult to compare. But I think that there may be benefits. However, we have had service closures, we've had staff redeployed, and we already knew that there was a disparity amongst access for this demographic beforehand for Black and people of colour, and it's been amplified by the lack of access that has happened during COVID-19, layered on top of the fact that people have now seen that COVID-19, oh, maybe that the health system isn't doing the best for us. A lot of people feel that these disparities that we're seeing in the COVID-19 are due to partly structural racism. So I do feel that it might amplify existing problems around people not wanting to interact with health service, including sexual reproductive health services in the long run. So that's a very broad overview of Decolonising Contraception's work and kind of what I've been up to for the next 3 months. And obviously I welcome any questions you have in the Q&A.
Thank you so much. That was a brilliant introduction. I know 10 minutes is not much to kind of try and talk about your whole organization's work and try and give an update on COVID, because there's been so much going on. And like you said, it's not just COVID, it's all of those things, all of those intersections that are now not just hitting us harder, but perhaps only just coming out to the front, even though they have been hitting us consistently over the years and decades. I'm sure there'll be some interesting questions following up from that. Thank you so much. On to our next speaker. Actually, just a note before we do that, please, when you're posting questions, please say, if they're for Annabel or another speaker, please say their name in their question. It will make it easier for us to direct the questions as well. Unless of course they're general questions, then that's okay as well. So our next speaker is Maria from Birthrights, and they've been doing some excellent work about promoting human rights in pregnancy and childbirth, and I think it's going to be also a very interesting introduction, because we've been hearing a lot about the impact on pregnant people in terms of COVID, but in terms of how COVID directly impacts being pregnant, but we haven't heard much about as much about services and how they've been affected and the difficulties that people have been facing. So without further ado, Maria, I would like for you to come in and introduce your organization and what you've been doing most recently and the impact that the pandemic has had on your work. I think you have to unmute yourself.
Sorry, there you go. Thank you very much for inviting me along to this discussion this evening. It's really interesting for me to hear more from people working in the field of reproductive health, as that's a bit sort of on the edges of our work at Birthrights. So Birthrights is a charity that is dedicated to improving maternity care through a focus on human rights. And we do that in a number of ways. So we have an advice line for women and any individuals, or for healthcare professionals who have queries about situations they're encountering and how human rights might apply to those situations in maternity care. And we also, in normal times, run face-to-face training for healthcare professionals in particular, but also for peer supporters. So we train over 1,000 people a year, and that's an important part of our work. And we take the intelligence that we learn from hearing what's coming in on the advice line and hearing what healthcare professionals are saying, and that informs our campaigning and policy and research work. So that's what we do as an organisation. It's obviously been an interesting few months for everybody. In terms of the impact on our work, we've seen a huge increase in advice line inquiries, as you might expect. In March, we had a 464% increase in inquiries compared to March last year. So that required quite a lot of rejigging as a team to kind of cope with that influx of inquiries. Helped by the fact that in some ways we can't do the face-to-face training at the moment, although we are looking at how we can move our training online. And we've also been responding to the pace of change in maternity services as well. Certainly at the beginning of the pandemic, it felt like every morning almost there was a new issue that people were inquiring about. So there's been a lot of press interest in how coronavirus has been impacting on pregnant individuals. There's been a lot of policy work in terms of working with the Royal Colleges and NHS England, and making sure in particular that what's happening to women around the country is being fed into policy decisions. So yeah, it's been a really busy time. Still lots to be focusing on at the moment as well. Starting to calm down a bit, but yeah, it's certainly been busy.
And you've had a report or a statement come out, if I remember correctly, from looking at your recent news. Connecting back to what we were talking about with Annabel earlier, what would you say is the impact particularly on Black communities, migrant communities? Have you been doing work particularly on that? And is it something that you're working on specifically?
Yes, so just like Annabel was saying in reproductive health, in maternity, there's been an awareness for a while, certainly since the Embrace report was published about 18 months ago, that there's a real issue with inequalities of outcomes in maternity care. So the Embrace report said that women from BAME backgrounds Black women were 5 times more likely to die around the perinatal period, and Asian women were twice as likely to die. And I think there's been quite a lot of focus on that in the maternity sector, but also a bit of a feeling of can we do, what can we change, what needs to happen. So it's been interesting that coronavirus has really shone a light on those inequalities again. It's really focused attention on that. The UCOS report that came out in May showed that 55% of pregnant women with COVID are from BAME backgrounds, which is hugely disproportionate to the 13% of the population that they make up. So it's obviously a real cause for concern, and has been an issue that's been of concern to us as an organisation for some time. So we've applied for funding to carry out an inquiry that will be starting in the autumn, and the idea of that inquiry is to really centre women's experiences. So we're really seeing our role as facilitating that inquiry. We really want to hear from women from BAME backgrounds, organisations who've been working in this field for a long time, researchers who've been working in this field, and really centre that inquiry on women's experiences. I think we've had a lot of looking at the stats and pondering what the next steps are, but I think the missing piece that we'd really like to help fill is looking at women's experiences and how they experience the system and what their experience of maternity care is.
Absolutely. I mean, all this data is very interesting, but in terms of real impact, real change going forwards, are you seeing real commitment from the government and the NHS to support real change, or do you think it will just stay on the stats and the data?
Well, I'm hopeful that the focus on it over the last few weeks since George Floyd's death and the Black Lives Matter march, and the fact that the government has felt forced to do something and set up a commission to look at these issues, I'm hopeful that will mean that changes are made, but I don't think there are any easy answers, and it's probably not my place to say what those are. But I think it's good that there's a real focus on the issues, and hopefully we can find a way forward to make some of those really underlying important structural changes, starting with education and training, and you know, focused on women's experiences and learning from those.
Thank you so much. It's certainly been the impression that we got from the other care webinars that we've run so far, that there is a lot of data coming out. There is a lot of information coming out. Like Annabel said before as well, all those inequalities are now coming out to the front. Whether we will see real change, obviously that's the hope. And that's also part of the reason that we're organizing these webinars, you know, to see how we can all come together and connect and make links and see where that can take us and support each other. Yeah. So again, if anybody has any links or any other useful information they would like to share, please keep posting them in the comments. I can see that there's quite a few things already. That's great. Keep sending in your questions. Please post the speaker's name in the comments if it's a specific question for them. And we have a couple more minutes. Maria, if you'd like to add anything else before we move on to the next speaker.
So I think we're going to talk about the issues that we've seen in maternity care over the last few months, and be interesting to compare how they relate to reproductive health. So some of the issues that we've been seeing coming through the advice line and, you know, over social media in our contact with healthcare professionals are issues around birth partners and whether they're allowed to be with individuals giving birth. And, you know, I think we ought to applaud the Royal Colleges in terms of they've been quite responsive and putting out guidance. So where it was right at the beginning of the crisis, we saw some trusts banning birth partners completely, just like that. But that got resolved fairly quickly because of this responsive national guidance. But we've continued to see issues around birth partners. So, for example, women with additional needs, perhaps physical or mental needs, not being allowed an exception to visiting restrictions. So not having support on the postnatal ward, perhaps where they need an interpreter, for example, or where they have a physical disability that needs extra support. We've seen issues around women being allowed to have their partner with them during an induction. And we've seen some interesting policies around women having to have their partner from the same household, which discriminates against single women or women whose partner is ill, or people who have childcare issues, for example. So there's been a whole set of issues around birth partners, and then we've seen a set of issues around services being withdrawn or cut back. So we've seen quite a lot of services withdraw home birth, for example, which are often very important to kind of more marginalised groups who might be more wary of going to hospital. We've seen midwifery-led services being cut back as well, and again, the importance of that relationship-based care doesn't go away even in a pandemic. We've seen some issues around women being denied elective caesareans, and we've seen things like water birth being withdrawn, often on very flimsy evidence. So there's still quite a lot of that's unresolved. What we've seen is services being a little bit sticky to return back to normal. So I think in some areas where they really haven't got many cases anymore, we still see trusts kind of sticking to the cutbacks that they've made, or, for example, only offering home birth to women who've had babies before or who have exceptional circumstances. So one of the things we've been pushing for is for trusts to be explicit about the basis on which they're making these decisions. And we'd really like to see greater transparency over that and a greater accountability. Because some of these withdrawals of services might be justified. So, that's the great flexibility of the Human Rights Act in many ways, that it allows those restrictions to be put in place if there's a good reason and they're proportionate. But it's not clear that that's always been the case. And it's been hard in some ways for organisations like us to judge whether some of those changes are warranted because of the lack of transparency about the basis for decision making. But I just want to finish by saying we have also seen some trusts do an amazing job and kind of pull out all the stops to continue to offer services that meet women's needs. And we've seen some maternity leaders who are really committed to continuity of care and for providing midwifery-led settings, and really understand the importance of those to all women. So, you know, there's been some bright lights as well to take away, and I think there are lots of lessons to be learned. I think a lot of people don't want to go back to the old ways of working. I think things have happened a lot more quickly. There's been a lot less bureaucracy. I think things have happened in weeks, which would have taken years to do before. And some of that is really positive, but we also need that transparency and accountability to go with it as well.
Thank you so much for ending on a bit of a positive note. I think that's really nice and heartening. And obviously, we know that there are a lot of issues, and we're going to be discussing a lot of them, but not everything, obviously, tonight. So it's really great to hear that there's been some positive change already. So our next speaker is Sarah, who's a clinical lead for early medical abortion at Mary Stopes UK. And I'm personally very excited because I've needed those services in the past. So welcome, Sarah, and could you introduce yourself a bit more broadly and the work that you do and how it's been affected by the pandemic?
Well, thank you to everyone for inviting me to come speak. I'm very excited about tonight. So as you say, I'm Sarah. I'm the clinical lead for the early medical abortion at Mary Stopes. Also, I'm a GP by background and also worked in sexual health clinics. So at Mary Stopes, we're a charity. There's the international side. I work for the UK side of things, and we have many clinics in England. We provide NHS funded abortion, which is about 98% of our work, also vasectomy, and also people can have self-funded abortions. It's, as I say, it's a really important service for women. It's really common. About 1 in 3 women have an abortion by the age of 45. And we just want to provide a really sort of safe, friendly and non-judgmental environment for women to come and have their abortion. COVID pandemic, as everyone's already been saying, has been a real challenge for us, many challenges. So, you know, accessing abortion's been a huge issue. You know, women might have problems getting on travel or school closures, like attending appointments because of childcare. You know, they might be self-isolating or shielding. You know, it's been really difficult for people. Also, safeguarding concerns. There's been a really big increase in the domestic violence reports we've had of about 33%, really gone up a lot, which I think is, you see that in other services as well, and just 20% increase in number of concerns about safeguarding. And obviously women are at home with abusers, and we need to be able to help them access abortion care safely. So lots of challenges, and also just generally with women, you know, people haven't had their support networks around them because they can't move freely the same during lockdown. So it's been really difficult. A bit like Maria was saying, we've worked very quickly to sort of try and sort things out so women can access abortion care quickly and safely. Fortunately with abortion, you know, the morbidity and mortality is low, but it goes up as people's gestation goes up. So obviously it's an essential service and people can't just wait. It's not the right thing. So what we've done to sort of be able to allow people to access our services quickly, we've set up, I think Annabel was mentioning this about telemedicine. So previously, prior to COVID, everyone had to come to have a scan first, and then they would have their medical tablets, and they were only allowed to take the second part home. But the government allowed women to take all of their tablets home, which we, you know, advocated very passionately, and we're there saying this really needs to happen. We really need women to be able to access during this lockdown. And so now not everyone needs to come for a scan, which means people can have a medical abortion at home, and we either can post them or they can come and collect their tablets. So that's been a really big change. And it's happened really quickly. Within 6 days of lockdown happening, women could access that service from us. And those who have to come in, you know, we've, you know, made sure it's safe for them and social distancing, etc. So that's been really, really important. In terms of safeguarding side of things, we've sort of a couple of things we've done. We've just set up a fast track pathway for women who are at home with domestic violence perpetrators. They can access, so usually we have like 2 calls people have to do, whereas they can just fast track straight to the nurse, and we make sure everything goes through really quickly, and make sure that they get their tablets safely, and that's really important for us. And actually people have said that actually they found speaking on the phone, actually it's been better in a way to have private conversations. It's probably quite difficult for someone like people to explain why they're going to a clinic. So actually people have found that actually it's been better to be able to do things on the phone, and all the feedback we've had has been very positive. Obviously telemedicine wouldn't be for everybody, but people have been very positive about the experience and felt they can speak very privately on the phone to us. So we're really pleased with that. And we've been working with other safeguarding providers to ensure that women can access abortion safely. The telemedicine also means that people can go home to have everything. They don't have to have part of their treatment in clinic, which I think is really important for women to have their abortion where they want to have it, which is for a lot of women will be, you know, it's at home. They can be at home taking the tablets, so rather than having to have them and then rush home as soon as they can. So it's been a really important change, and we're really pleased that we can offer that. Just thinking also about how essential it is, just in the sort of week or so before lockdown happened, we found that our DNA rate had doubled. So we're really pleased that we can offer people treatment at home, because people just can't get to clinics the same. It's been so important. So that's what we've been doing during the pandemic. And we've all worked very hard, as Maria was saying. We've all been very busy, so it's been very tiring, but really worth it. And we hope that we can continue offering that, but it will depend on what the government decide to do. But obviously we've made our thoughts very clear on the subject. So that's what I was going to say.
That's really great. Thank you. I think you've covered all my questions. Maybe you could just expand a little bit on the idea of why is it so essential that the access is maintained, because I think it takes us back to the core question of the meeting tonight, of, you know, seeing reproductive healthcare as care, as healthcare. Yeah,
I mean, it's so essential. I say, you know, as I said, you know, people can't wait. As people's gestation goes up, the risks go up to that woman, and it's not okay to wait. And I think we've seen in other countries where it hasn't been seen as an essential service, the awful stories that I'm hearing is just terrible, that people are taking drastic action to try and induce an abortion themselves, or, you know, it is so essential, or trying to travel to England, which is very difficult to get services. So yeah, it's not a scenario where you can just wait. It's so important to do it quickly, and the guidance says we need to do it quickly. Everyone, you know, should be accessing it within a week. So I'm you know, it's so, and as I said, it's really common. You know, if you think about 1 in 3 women by the age of 45, you know, it's a lot of people, and we treated, when I last looked at the figures, over 5,000 women with telemedicine in the period of sort of lockdown. So, you know, there's a lot of women who need access. And, you know, as Annabel was sort of saying, you know, the redeployment in the NHS has meant that the NHS didn't maybe initially provide as much abortion care. So the CCGs allowed, which are like where they commission the services, allowed women to choose other services to access their healthcare. So we've had more women from that side of things as well, which is great, that people are being flexible and not just, yeah, as you say, the bureaucracy has reduced to allow women to just be able to access it. So it's really important, and I hope this feeling continues, because it's so important. I think the problem with abortion is there's a lot of stigma around it. So it's working to continue to try and smash that stigma, and people to talk about it more, because I don't think people realise how often it happens. So and we don't want that to prevent people coming. We want people to know we're there and we can help them.
Absolutely. Thank you so much. and continuing us on the subject of abortion from a bit of a different international perspective is Mara Clarke from the Abortion Support Network. And I just had to mention that Mara is describes herself as abortion funder on her Twitter account, which I thought was awesome, so I just thought I'd mention it. Yes, Mara, welcome. And could you tell us a little bit more about the work that you do and how it's been affected by the current situation?
Of course. Thanks for having me, and thanks to everyone for being here and for giving me a reason to dress up, or let's be honest, get dressed at all. So the Abortion Support Network is an abortion fund, which is a group that helps people pay for and access abortion. And this means that we think I can't afford an abortion should never be the only reason someone becomes a parent. So we started in October 2009, providing services to those in Ireland, Northern Ireland, and the Isle of Man. In February 2019, we expanded to Malta and Gibraltar. And in December of 2019, we launched a group called Abortion Without Borders, bringing together 6 organizations in 4 countries to help women and pregnant people in Poland access abortion. And since turning our phone on in October 2009, more than 5,800 people have contacted the Abortion Support Network helpline. But since we turned on the Abortion Without Borders Polish helpline on the 11th of December last year, over 2,000 people have contacted just that one helpline. So, you know, December 2019, we're all excited, and then whoops, but we'll get to that in a little bit. So our service users have ranged in age from a woman of 53 to a girl of 12. They were married, single, divorced, in or escaping abusive relationships, had children, didn't have children, never wanted children, had used birth control, had thrown chance to the wind, had been sexually assaulted, were working full time, were unemployed, were homeless, were struggling with mental health issues, were migrants, asylum seekers, citizens, students. Basically, our callers had in common but 4 things. They were pregnant, they wanted to end their pregnancy, they didn't have the money to do so, and they never would have thought that they would be calling a group of strangers in another country to ask for money to help pay for their abortion. So an abortion fund is not for most of the people who need abortions, because most people who need abortions who live in a country where they can't access it still have access to things like the internet or a job or a bank account or credit cards or friends and family who can help them. And we're here for the people who are prevented, usually due to a combination of restrictive abortion laws and poverty, from accessing that care. So bad abortion law takes an unplanned pregnancy and makes it into a really economic thing, where for women and pregnant people with money, it is an inconvenience, but for women and pregnant people without money, it is a catastrophe. So first, here's what Abortion Support Network doesn't do. We're not doctors or counselors or lawyers. So we don't ask medical questions or provide medical advice or legal advice or counseling. So if someone calls us and says, oh, I'm pregnant and I don't know what to do, we signpost them to a reputable pregnancy options counseling where they can explore all their options. We're here for the ones who they know they want an abortion and only money and logistics are standing in their way. We also don't campaign. There are many wonderful individuals and organizations who have worked and continue to work to ensure there's free, safe, legal, local abortion provision in all of our countries. ASN is the Band-Aid or the plaster on this issue, and the campaigning organizations are the cure. What we can do is any of the following: help arrange the least expensive abortion and travel, give information about how to book an appointment, help book appointments for limited English speakers and people who don't have phones or internet access, information on how to travel to England without a passport or a photo ID, info on who does and doesn't need a visa to travel to what clinics in what countries, directions for how to get from the airport to the clinic, funding, big part of what we do for the travel and abortion procedure, accommodation in volunteer homes or paid accommodation near clinics, and just sort of creative problem solving around childcare and other logistical issues, and of course, information on the reputable online providers of early medical abortion pills. For those who can get them, they are, I'm not joking, life-saving. Sarah will agree with me, I think. And the one thing we really give is the knowledge that while their country and other people around them might have turned their back on them, the hundreds of people who make up Abortion Support Network, our 3 staff, our volunteers, our donors, our supporters, are standing with them in solidarity, and they're not alone. So we don't ask our clients how they got pregnant or why they want abortions, and we don't ask if they're women because it's not our business. Our only criteria for funding are financial need, and if we have available funds, which I'm happy to say we haven't run out of since 2012, go us. Now, the big question of the evening is, how has the coronavirus impacted our work? And I mean, you know, we thought the Icelandic volcano was going to be our biggest obstacle, followed maybe by Brexit. But on the other hand, while travel restrictions and lockdowns have created obstacles, from an abortion funder's perspective, these are merely additional obstacles. Like, our clients and service users already have to overcome so much to get an abortion. So what's a few more? I will say that when travel restrictions were announced, we saw a massive spike in calls and emails from all of our countries. And we've seen that we're getting more calls from people who aren't even pregnant yet, who are really, they're so freaked out that they're like, okay, wait, I live in Malta, there's no planes, it's an island, there's no abortion, what happens if I get pregnant? Yeah, so, but we've also got the same calls from Ireland and Northern Ireland and Poland and Gibraltar. Malta has had the most difficult situation because not only have the airports been closed, but unlike Poland, where the airports have also been closed, in Poland you could still take a bus or drive, whereas in Malta, unless you're a really strong swimmer, you're stuck. And for a little while, post was delayed by 2 to 3 weeks, and people waiting for early medical abortion pills were starting to really panic, but things were okay in the end. Some of the things that have impacted us, Sarah mentioned some of the obstacles they see at MSI, like having to explain why you're popping out to the abortion clinic. I mean, our clients have to pop out for a few days. But other things that have happened were that clinics in England, Germany, and the Netherlands won't treat anyone showing symptoms of coronavirus. Poland and Ireland have both instituted a 14-day self-isolation period for anyone returning from abroad, although Poland has now ended that. Our volunteers in England, Holland, and Germany, a lot of them have opted out of providing accommodation during this time. And at the same time, many hotels, B&Bs, and guest houses have shut down. The 3 clinics we work with in Amsterdam are still open, but one is reduced provision to 13 weeks. At least the other 2 now are still going to 22 weeks. For the first few months of coronavirus, flights, trains, and buses were canceled almost as quickly as we could book them. Now the scheduling seems to be okay, but the capacity is greatly reduced because of social distancing, and costs have gone way up. There was a brief period where many of us working in abortion care were worried about the global supply chain for mifepristone and misoprostol. It was a real worry for a little while because all the ingredients for those medications, there are some European providers, but the majority of that stuff does come from India and China, which were basically shut down. So another thing that happened is the EU closed to non-EU and UK residents. So if you were from South Africa but living in the Republic of Ireland, you need a visa to travel. And nobody has gotten that visa from Ireland to the United Kingdom since the Brexit vote 4 years ago. So we've been sending them all to Holland, but then Holland shut. So that's been, we've been very, very fortunate that everyone from Ireland who has contacted us while being too late to get a legal abortion in Ireland has been within the time frame when they could still have a safe abortion with pills obtained in other ways. Women are finding it harder to get childcare, both because journeys are taking more time and because people are practicing social distancing. A lot of clinics in the UK have shut down. I know the BPOS clinics in particular, although what's interesting is they've shut more clinics, but they're providing more services because now all consultations are done on the phone, and everybody under 10 weeks is getting pills by post who can. And yeah, I think that's, you know, that's just like a random off the top of my head list of obstacles. But before we all stick our heads in the oven, we have some pretty good news, which is that we've yet to have a situation where COVID restrictions prevented us from getting someone to their abortion, right? So while we are kept up at night by the people who don't know they can contact us for help, the fact is people who want abortions are determined. And if 50 hours on 6 different buses and trains between you and not having a baby is what it takes, you're gonna grab a book and settle in. And so we've been very successful. Now that travel restrictions are starting to ease, we actually know that we're at the very beginning of seeing what longer term impact coronavirus has on abortion. We know that some countries have made telemedicine available, such as England. Surprisingly, the Republic of Ireland was the first European country to do that. Go Ireland. But we know that other countries, such as Romania and Italy, have made legal abortion access even more difficult. And Poland, for instance, really tried to get in there during the virus to go from having like the 3rd worst law in Europe to the actual worst law in Europe. So it's hard to say what's going to happen in future. We also expect there will be an increase in unwanted pregnancies due to lack of access to contraception, or worse, women and pregnant people being in lockdown with abusers or experiencing reproductive coercion, or that more people will choose abortion due to economic insecurity as we all slide into a global recession. Another worry is that there may be more people in Europe who need abortion beyond the 1st trimester. Most of Europe does give abortion on request to 12 or 14 weeks, but very few countries give abortion on request beyond that point, with with the Netherlands and the UK, meaning England, being the best places for that. But England might be out of the game once Brexit happens. And we already have one of the 3 clinics in the Netherlands that went to the Dutch legal limit, reduced the limit because of COVID-related staffing issues. So who knows? But on the upside, we abortion funders are creative problem solvers. We plan for the worst and hope for the best. And we're seeing reasons to be optimistic. I mean, first of all, now like many more people know what it's like to live in a country with a bad abortion law. So maybe that will help with liberalization, fingers crossed. And also, it's been great to see the destigmatization of self-administered early medical abortion pills. And as always, we're doing what we can, as we can, taking each new challenge one step at a time. I'd be remiss if I didn't mention that almost all of our funding comes from private individuals, and I see a couple of you here, so thank you very much, and thank you all for your time.
Wow, thank you so much. Yeah, there was a lot there, so I'm still kind of processing.
I can share my talk.
No, it was all really, really interesting, and you know, we all, I'm sure, were fascinated. And so the next person I've got speaking is Paula from Brook charity. Paula is also a fellow Polish feminist. So I was glad that Mara mentioned Abortion Without Borders. They're doing some amazing work, but also we'll talk a little bit more with Paula about what's going on in Poland and about sexual education and access to sexual health care more generally in the context of the pandemic. So Paula, welcome. Could you tell us a little bit more about the work that you do and the impact of the pandemic that you've seen?
Hi everyone, thank you Magda for inviting me and Brooke. So I'm a relationships and sex educator. I work for Brook Charity, which is a sexual health and sex education charity. Across the country, across the UK, we have a network of sexual health clinics for people under 25. Now during the pandemic, we really try to keep them open. So most of the sexual health clinics run by the NHS have closed down. As you said, the staff has been redeployed, but we really try to keep them open for young people because as also you, Sarah, said before, like sexual health clinics, abortion clinics, and not just service providers. It's very important to remain having these services also for safeguarding reasons. These are safe spaces, especially for young people, that they can have these confidential conversations with staff. So that's why it's super important also regarding their mental health and well-being. That is places where they can ask all questions and just talk to someone. So we also provide one-to-one counseling as an organization, depending on the context in different parts of the country. But also we try to keep it during lockdown. So we provide special support regarding relationships and sex education for young people, which is one-to-one. And now we do it over the phone, and it works. So we know that young people engage with us, and it's really great that we can maintain these services. What I do, I work in the education department, so I deliver relationships and sex education. By the way, today is the RSC day, so today we can celebrate sex education, which from September 2020 is becoming mandatory in the UK for the first time ever in schools, which is amazing. It will be delayed a little bit because of COVID, but the law has been introduced. So we have this legal framework, and now schools will have to organize these lessons. So I go to different schools, and I teach all topics related to sex and relationships, and also I train professionals who work with young people to make them feel more comfortable while discussing all these topics. Because, well, it can be a challenge for adults to talk to young people, which we can also help with that. So now most schools, I'm sure we don't have any official statistics, but I'm sure that most schools have given up on providing any kind of relationships and sex education. So young people don't have access to it right now, but we hope that once they're open again, all these lessons will be available again, because we just can't have such long breaks, and these topics have to be discussed on a regular basis. Also topics like healthy relationships or consent. Again, as you all said before, these are the issues that are coming up in lockdown even more, and that's why it's so important to talk to people. I also work in youth clubs, so we also target the most vulnerable young people. So we do a lot of outreach, which again has been difficult in lockdown, but some of youth clubs are doing online sessions with young people, so it's really great. We can access them on Zoom or Instagram, anywhere where possible. So we can also do sessions like this, which is really great. So this is the overview what's going on in the UK right now. When it comes to Poland, well, for the last 30 years, like no Polish government was actually in favor of people having autonomy over their bodies, also when it comes to reproductive health. So the situation has never been great, but now every year it's worse and worse and worse, and Poland is on the bottom of every list when it comes to, for example, access to contraception. So the European Parliament every year provides a map of all European countries regarding access to contraception, and now Poland scores the worst. So it has really, the situation is really deteriorating, and now the Polish government is openly against comprehensive sex education. Although we have a law that potentially could be good, because in the Polish law, like in the UK right now, we should provide sex education in schools. There is a school subject like this, but it's very ideological. It's not really comprehensive sex education, and even if it's organized in schools, it's more of a Catholic version of sex education, which is not scientific and not based on any facts. So it's this is basically a religious ideology, and it doesn't really help young people. So there is no comprehensive sex education. So I'm a member of a volunteer sex educators group in Poland called Ponton, which is affiliated with the Polish Federation for Women and Family Planning, which is a big organization working in the field of reproductive rights. What we monitor, again, access to contraception, also to legal abortion. As Ponton, we provide relationships with sex education in school, but also online, which is also very useful now in lockdown, but we have always been doing it. So we support them. They can ask us anonymous questions on our online forum. Also, we have a hotline for young people where professionals, educators address young people's questions. So these are the things that can easily be done in lockdown, and it really helps. Recently, there were two in the Polish Parliament, two fundamentalist groups tried to push for even more radical laws. So one regarding abortion and one regarding sex education. So actually, in the Polish Parliament, there is a bill that would penalize talking to young people about sexual health or access to contraception, so providing any kind of sex education to people who are under 18 could be potentially fined with jail. So there could be, but if the bill passed, it has not happened yet, and I really hope it won't. But if the bill was passed, so sex educators like me could face up to 3 years in prison, which is absolutely ridiculous. So I hope it will never happen. However, the president of Poland, the big Polish government is very clear. So they're basically against comprehensive sex education. And we have presidential election on Sunday, actually this Sunday. So the whole presidential campaign, the enemy that they picked was the LGBT community. So the government picked this part of the population to basically target them and to dehumanize them. So a lot is going on in Poland right now, and we like more and more young people. Even last month, one young person committed suicide because he could not cope with the whole situation around LGBT rights. So according to ILGA, the LGBT organization, also Poland now is one of the worst countries when it comes to LGBT rights. Yeah, many bad things are happening.
Thank you so much, Paula, for doing a very comprehensive introduction in 10 minutes, or as much as you can anyway, within 10 minutes. I know there's a lot going on, and it's absolutely mind-boggling. So I'm sure we'll come back to the different points that you made in the discussion. Hopefully there'll be time for a lot of questions. And on that note, please do keep posting your questions. We'll have about, by the looks of it, we'll have about 45 minutes for discussion. So should be plenty of time to answer everything. And our last speaker, last but not least, is Lucy from Fumble. Lucy, thank you so much for joining us and waiting patiently as the last speaker. Could you tell us a little bit more about the work at Fumble, that you do at Fumble, and how it's been impacted by the current situation?
Yeah, of course. Thanks, Magda. And yeah, absolutely my pleasure to get to listen to all the other speakers. And thank you to all the speakers. And thanks to everyone for coming to listen as well. It's really great to be part of this panel, because I guess one thing it exemplifies is the way that despite the pandemic, people are still coming together and amazing work is still being done, and we're still able to share that, which is great. Very heartening to hear. So what Fumble is, we're a digital platform and we're a sex education charity, and we're aimed at young people. So anyone under the age of 25 in the UK. We're particularly honing in on the 11 to 21 age bracket within that, simply because it's such a huge range of young people and different experiences, different backgrounds, different realities in their home lives and their relationship lives and their cultural backgrounds. Yeah, so it's a huge demographic to try and cater to and offer what we are offering, which is happy, healthy, engaging digital sex ed content for young people. and we cover sex, relationships, bodies, and related topics. And I think quite importantly to mention, we cover mental health for young people, because we see mental health as being really interwoven into everything that is included in the bracket of sex and relationships education. So I'll just tell you a bit about who Fumble is. We're all a team of volunteers. We're all young professionals working across media, health and education in the UK. Fumble has just successfully got its charitable status in February this year, after being launched back in the start of 2017. So we've been running it as just a group of volunteers until now. And we've just got our charitable status, which is really exciting. And the reason we launched Fumble initially as a group of young people who grew up alongside the internet was that, being one of the first generations to have that experience, have our puberty years informed by the digital landscape and understanding the challenges that poses young people, we saw that there was currently a big gap in the high quality provision of digital resources for young people and sex and relationships content. Fumble is also fundamentally a feminist project. It's about encouraging and equipping young people to have healthy, intimate relationships with one another, regardless of their gender, and to promote women's sexual health, particularly women and non-binary people who've traditionally been overlooked by conventional discussion of this topic, which again, as I mentioned a few times, the topic of taboo and the topic of stigma holding back, particularly related to abortion provision. And we also see that across the board in sex ed. It's not a sexy topic, ironically, and we do sometimes come up against barriers in trying to do what we do, which is just equipping young people to have really healthy, responsible relationships with each other and with themselves primarily as well. So we're aware that the internet poses a few challenges for young people trying to do that, because there is quite a lot of unhealthy content out there. We see that a lot of young people are using pornography because conventional sex ed channels isn't equipping them to understand sex and intimacy. So they're actively seeking out pornography as a resource for sex ed online, which, regardless of what you think about any kind of pornography, that's not ideal as a way of understanding a healthy vision of intimacy. And things like safe sex, safe sexual practices, condom use, consent, all of these questions are very often, I don't want to say in every single instance of pornography online, but very often in online pornography, those kind of questions are overlooked or misrepresented. So yeah, we want to be an alternative online resource that's really engaging. So young people using social media, obviously we know, and they're interacting with each other, and they're building communities, and they're building their sense of themselves and the world around them through using social media and digital content. And so we want Fumble to be in that space with them and be authentically responding to the kinds of contents and conversations and experiences that young people are having today, both on and offline, but primarily we're a digital resource responding to them in the digital context. And we think that's really important to be digital because of what I've said, that there's a lack of currently really healthy, positive content out there. And also because young people may have access to sex education. I think, as Paula said, it's due to be introduced in all UK schools at long last from September, but we're aware at Fumble that the provision of that is likely to be very patchy. I saw one study that suggested the amount per school, that the funding for this would amount to about £250 per school to implement, in some cases, a whole new sex and relationships education syllabus. So we're aware that will be patchy at best. We're also aware that in the school setting, among their peers, in front of perhaps their whichever teachers tasked with delivering the relationships and sex education, young people might not feel comfortable to ask those questions that they're having. That might be a bit more intimate, a bit more awkward. And so they're, regardless of what they receive in face-to-face settings, we're aware that young people will also turn online, of course, in this digital age to explore these questions. And crucially, what Fumble does to try and always remain relevant to that is that we use a co-creation model with young people to develop our content. I put in the comment box one example of our content, which is an audio package we've done recently on abortion for young people. And And we're increasingly basically using the experiences of young people to inform exactly what we do. And we're also currently recruiting a youth advisory panel to really take that up a gear. And so in terms of the co-creation, an example of the work we do in that regard can be seen in a research project that we're currently doing with a sociology academic at the University of Surrey. She's working with a school that's identified that it has quite a lot of problems among their young people population in terms of issues relating to relationships and sex education. Particularly, they have an issue as well with the bystander intervention, so that young people understand in many cases what's wrong in terms of things like sexting, bullying via sexting, that kind of issue. They understand that that's wrong and they don't want to participate, and generally are not participating, but they're also not stepping in or being able to make a meaningful intervention in that. So that's what we're looking at with them. So we're working with a really engaging and inspiring group of young people from that school to try and address that. And so what we're doing as Fumble, we're consulting on this research project, and we're working with those young people to develop new digital resources that speak with an authentic peer-to-peer voice. And that's basically at the heart of what we want to be doing at Fumble. And so then in terms of the impact of the pandemic, that's another reason why it's so important that we have digital resources, because never has there been a more obvious instance of how important it is that we have happy and healthy resources online that are meaningfully responding to what young people are looking for and the questions that they're asking. We know that, for example, the UN Department of Economic and Social Affairs for Youth has identified that young people are disproportionately vulnerable to the impact of COVID, and we certainly are hearing that from other organisations that work with young people who we're partnered with or in contact with. We hear that particularly organisations that generally deliver face-to-face or in-person services and don't have the resources or expertise perhaps to deliver those equivalent services online. They're really worried about young people and where they can direct young people to find equivalent resources. And particular issues that we hear young people are experiencing as having been exacerbated by the COVID-19 situation, and particularly in the lockdown context, are social isolation, mental health concerns, and online pressures. Yes, so more than ever, young people are turning online for support and advice, and that's what we're trying to give them in a really meaningful peer-to-peer kind of format.
Thank you so much, Lucy, and thank you to everyone who has spoken so far. I'm going to open up to questions now, and I've had the first question for Annabel. I haven't got the name of the person who sent it, sorry, so I'm just going to read it out. And if you do want to come in, please remember that the meeting is being recorded, so if you're one of the people who are wanting to ask a question and you want to ask it yourself or add anything to the questions I'm reading out, you're welcome to come in, but do let us know if you don't want to be recorded, and we can pause the recording. So the first question for Annabel. Annabel, how would you like to see other sexual and reproductive health organizations integrate decolonizing thinking methods into their work? And thank you for a wonderful overview of your work, which is so needed in the sexual and reproductive health world.
Thank you very much for the question. So I think when it comes to decolonizing, and obviously the word has been been about for a few decades, and it's not a new concept. I think it's really important that people understand that you have to unlearn and decolonize your mind, and it's still a a continuous process of learning, and even for myself. So it's quite difficult to say what the right thing or how to integrate a model is. I think what's imperative is that people do the reading and listen to people's tried and tested approaches that in terms of that have tried to decolonize certain aspects of healthcare or do decolonizing methodologies. There's a really great book called Decolonizing Methodologies, to understand what that looks like in terms of engaging communities, interrogating our ideas and belief systems, and kind of accepting the status quo as is. And that is how you start the process, and then what you need to do becomes a bit more apparent. I think people feel or move towards understanding decolonizing almost like a diversity and inclusion kind of project, and actually it's the exact opposite, and it's difficult and it's long-winded, because it's talking about long-term sustained change, and I probably actually won't see most of the fruits of my labour or what I want to see maybe even during my working or professional life necessarily. So I think we got here through kind of centuries of a system and kind of like sexism and racism. So we're not going to get to the system that we want to have overnight. It's going to take a long time. So I'm not saying that people shouldn't try these things, but I think it's really fundamental to go back to the basics and read around the subject and educate yourself. And it takes a very long time, and reach out to organizations that have tried and tested things and are also trying to understand, and then collaborate and just go from there.
Thank you so much. I'm just catching up on the questions now because I was trying to listen to everything. So I've actually got another couple for you, if that's okay, Annabel. I hope
yeah,
you've got
that's
support
fine.
to that.
If people don't get bored.
No, I think they're fascinated. They're asking all the questions to you anyway so far that I've seen. Do you have any thoughts about women who want to use methods of contraception that their healthcare provider disapproves, like natural family planning and withdrawal?
So I think in terms of, actually this is quite pertinent to the work that we do, because of the systems of oppression that a lot of minoritized groups have faced. They actually have a deep suspicion of hormonal methods of contraception, sometimes, not all the time. This is again a generalization. So actually I'm asked about natural family planning quite a lot, and people using herbal things or more, and as a lot of people on the call know, and a lot of medical professionals, actually a lot of the medicines that we take, like misoprostol, were just refined from plants. Essentially it's just a more concentrated version. So but it comes up quite a lot. So in terms of natural family planning, I think there's a lack of understanding amongst medical professionals, where obviously educated in like a medicalized system. So we talk about medicine and using pharmaceutical agents, and that's like what we're taught about. And patients are often kind of left to figure out natural family planning on their own, which I don't think is necessarily correct. I think what I always say in relation to a lot of the people that I come across that want to explore that option is that natural family planning requires a lot of diligence. It requires time for a lot of people. It requires like a regular cycle, and actually a lot of because of all the structural things I've actually discussed, that doesn't actually work for several of the people that are proposing this method to me a lot of the time. And actually sometimes natural family planning is much easier when you're in a regular relationship, for example, because you can time your intercourse and things like that. So I think there is a lack of awareness though amongst medical professionals. Most of the time when somebody brings it up, people just kind of laugh it out of the room, and I think we have to have a better approach in terms of saying, is this right for you? I also ask patients, for example, you know, how important it is for you not to be pregnant, and that is a very important question to understand in relation to what method somebody wants to use in terms of reliability and if it's actually going to work for you. And so I think, yeah, there's quite a lot of work to be done about, you know, doctor-patient interactions and having a bit more of an in-depth conversation about things that are not medicalized.
Brilliant, thank you. The other one was actually just a comment on how brilliant the talk was, and another comment from Mara saying that you're a national saint in Ireland. That was a nice one, so I'll read it out. I'm not actually seeing any more questions in the chat, but we have allowed participants to unmute themselves. So if you'd like to come in with a question, now would be a good time. Otherwise, I'll take the opportunity to ask my questions. Sorry, go on.
Sorry, this is Gail here. There is a question for Lucy, which I mean, somewhere got lost in the technology. I can't remember what it was now. Oh, I know, here it is. Shall I ask it? How is, can you hear? Sorry. How is the TV programs and series impacting young people's attitude on sexual education? 13 Reasons Why. Is that correct? Have I got that right?
That's correct. You've got that right. I am not so au fait with 13 Reasons Why. I do know that it's quite controversial in its depiction of suicide. Has been quite roundly criticised by other youth organisations that I'm aware of, including Young Minds, for example. One other, just on that note, Sex Education is another Netflix programme aimed, well, it's a comedy drama basically, and I wondered, I'm 28 and all of the team at Fumble are 30 or under, so we are technically sort of young people ourselves, but our target audience is up to 21 really, so we are still, and things move so quickly for young people. Social media trends change so quickly, social media channels that they're on, but also the experiences they're having, the language that they use, and it's quite it changes it's quite varied among, even within the target audience we're aimed at. So I always feel quite an old fogey, even though I am only 28 really. But so we did ask a group of year 12s recently, do they watch Sex Education? Because it is a really good, like, inclusive, generous, lovely piece of comedy drama for young people, and they did, loads of them put their hands up, so that was quite heartening to see. So they are receiving good quality popular culture as well, if that helps.
Thank you. Siobhan, would you like to come in? You had a question that you said you might like to ask.
Great, hi, thanks. Yeah, trying to get my way around Zoom. Yeah, my question is for Sarah at Mary Stopes, and really it's just regarding telemedicine and the recent changes that have come in lockdown. Obviously the idea would be that something like this could continue permanently going forward, and I suppose I'm just curious to know, are there ways that people or organisations can kind of support organisations like yourself to show their support for this to the government? Are there sort of existing campaigns? I'm not really up to speed on this, in all honesty, so I was just wondering almost the best way to show support for that.
It's a really good question, thank you. I mean, everyone was going very hard to try and get the government to approve it in the first place, and they did. I don't know if you're aware, but they did a U-turn on it to start with, then U-turned again, thankfully. But yeah, it's so important. Writing to your MP. I know it was in the media to start with, so you know, if you've got any sort of local connections to papers, you could write to them. You know, it was very hot topic right at the start, but yeah, mainly through your MP. I mean, you know, I suppose some people may feel like, well, will it make a difference? But if you don't do it, then it definitely won't. But if you try, then it may make a difference. And it's so important. I mean, prior to COVID, people could have their second part of their tablets at home, but still that's not the right choice for people. You know, to say you have to have part in the clinic and then go home. I mean, that's, you know, for people traveling a long distance, their abortion might start on their way home, which is just awful. So, you know, it's really important. So we're sort of campaigning, you know, hard to how to continue that, and we hope the government will continue it. But yeah, and on the Mary Stopes website we've got loads of information about this, so, you know, and we've got chatter on social media as well. So just people sort of supporting it, raising the issue is really important. So yeah, we hope to keep going, and I know the other providers are doing that too, like BPAS and you know, NewPAS. So yeah, no, carry on. If you don't mind writing to your MP, that'd be amazing.
Thank you, thank you.
And we've got another question to you, Sarah, about clinics and protests. How has the pandemic lockdown affected those?
Initially, I mean, I'm based in Bristol, so just I don't know if people know this, but in West London there's a like a buffer zone, so they're not allowed to go past a certain area. But in most places you don't get that, so it's really unpleasant for people coming to the clinic as well as their partners. It's really unpleasant. And so during lockdown they weren't allowed to, you know, people obviously weren't allowed to go. But I'm afraid as soon as they start relaxing things again, we've got our protesters back, which is really sad for women. And you know, we're looking at you know, trying to get a zone so people don't have to be so aware of it. You know, I appreciate people are welcome to their opinion, but I think it's very unfair to do that to people coming to the clinic. I think it's really unpleasant, and often saying things which aren't factual as well. So unfortunately it's coming back, but again, we're campaigning to try, and other groups are as well, to stop protesters being able to do that. I don't know if that answers the question.
Thank you so much. Sorry, give me a second.
Just on that topic, can I just add something?
Yeah, sure.
Something that's really commonly kind of not highlighted is, I'm quite lucky that I do my abortion work, well, lucky, in NHS service, so we don't get protesters outside quite as much, but my consultant does work at BPAS quite a lot, and Leicester BPAS has quite a lot of protesters, and they hold vigils outside, and it can be obviously quite distressing, but I think people also need to recognize that there's actually still a lot of stigma about abortion provision within medicine. So actually some of the and because I work in an NHS service, rather than working in a Mary Stopes or a BPAS service, which is outside of the hospital context, a lot of the abuse I receive actually is from my professional colleagues, and it can be quite, you know, subtle sometimes. It's like, what are you doing? Some of it's overt, where it's like, how many, you know, babies have you killed today? And you know, I think it's really important when people are talking about what we can do to address these things. First of all, obviously you call things out. It's quite difficult, especially when it's somebody in a position of authority or more senior than you, but I think it's really important that people, I know, like, are visible about their advocacy if they can be, and also talk to the people around them. But I just thought it was an important thing to flag, that some of the stigma and taboo, often we don't realize how pervasive actually it is and where it is. And a lot of O&G trainees opt out of doing abortion provision, and we're having a bit of a crisis of abortion providers at later gestations in the UK because of this very reason, because there's a hostile environment that's been created for them in terms of their training.
Thank you so much for coming in and adding that, Annabel. We've got a question from Dara to Lucy about the research project Fumble is doing with the academic sociologist and the school. You mentioned the project is looking at how young people are aware of bullying and sexually abusing each other, but not speaking up. How do you balance encouraging young people to speak out, but also making sure that those who don't speak because they're afraid or ashamed don't get weighed down by guilt they might not get relief from for a long time if they think that their silence was as bad as the crime?
Yeah, it's a good question, and I think that's a really good instance to illustrate why we at Fumble see mental health being so interwoven into all of these questions, because the issues that are under the umbrella of relationships and sex education will have impacts on to people directly, and we see that through direct accessing of healthcare that an individual might require, for example, in abortion provision. But we also do see them impacting people indirectly in like the social cultural narratives that come up around such a taboo area of society. And it's very curious that sex is so taboo when nearly everybody has sex and nearly everybody will at some point have sex. Certainly everybody has some kind of sexuality, albeit they might be asexual. And it's a foundational part of everyone's identity and self, and relationships are certainly a foundational part of society. So yeah, it's exciting to see things like a compulsory UK curriculum being introduced on relationships and sex education, because it gives legitimacy to organisations like Fumble or like Decolonising Contraception or like Brook, who, I mean, even as a national charity, Brook doesn't perhaps get the weighting of other national charities, of its standing and of its credibility and of its skill and expertise, because of the nature of what it's dealing with. And Annabel, I think you mentioned not enough obs and gynae trainee doctors coming through. All of that is all related together to this sort of wider taboo and shame and stigma that sort of relates to the question I got asked. But to answer it directly, I think, I mean, in the case of someone who might be struggling with not intervening in an issue of sexual bullying, that's obviously a very personal, very difficult thing, but I would just recommend seeking professional support if that is something that someone's struggling with.
Thank you so much, Lucy. Amy, would you like to come in and ask your question?
Yeah, so my question was kind of about the title of the event, Reproductive Health Care is Care Too, and I was wondering whether people had thoughts on why it wasn't considered as care in the same way as other areas, if that is what you thought.
You go for it, Mara.
Yeah.
Oh, so I think it's really interesting. I think it's sort of like you look at abortion, but also things like miscarriage and fertility in general, and they're all looked at, and menstruation, they're all looked at these like dirty, secret, shameful, awful things. And I think it's just about judging women. And it's the whole entire circle. Like when you get pregnant, don't tell anybody. You know, they don't even tell you that 20% of pregnancies end in miscarriage naturally until you actually get pregnant, right? And then you're not supposed to tell anybody you're pregnant, because if you have a miscarriage, oh, you wouldn't want to bother them. So then if you do have a miscarriage, then you're telling your joy and your grief at the same time to people who haven't been with you on the emotional journey. So they don't know how to react, and it just becomes this whole big dirty secret thing. And I think that is something that is in every aspect of women's health. You know, and I don't know why, other than that it's grossly unfair and patriarchy.
That was a really fantastic answer. The only thing I just wanted to add is obviously decolonising contraception, we talk about history a lot, and firstly I will just say yes to everything that Mara just said, especially in relation to like miscarriage. And I've been dealing with miscarriages during COVID a lot, and there's a lot of secrecy and science around that, I think, and shame, and people need to talk about that more. But a lot of this, I think, comes from the patriarchy of medicine. To be honest, and this is why I say we have to decolonize and go back to the beginning, and medicine has kind of moved with the society that we have, but we also have to force it and the boundaries to move. It doesn't kind of willingly shift. And if we look at medicine, a lot of people on the call will be very familiar with like the stereotype of the hysterical, you know, hysterical woman. If we cut things off, then she'll be less hysterical and be less sexually rabid and whatever. And then layered on top of that's like racism and the fact that, you know, all big buttocks, hypersexual, let's ferry this person around like Sarah Bartman was. So I think it fundamentally, reproduction and sexuality has always been this othered, needing to be controlled, area, and it really just stems from that, really, in terms of, you know, how it's perceived. And I don't think we've really truly got away from that. And I could talk extensively about, if you look at similar conditions like pelvic pain and how that is managed, depending whether it's a woman or a man, and if they get the pain relief or investigation that they require. I think often we find that it's handled and managed quite differently, and there are some papers around that. So I think it does boil down to the fact that the sheer weight of most reproductive issues affects a certain demographic of people. Poor sexual health mostly affects kind of queer, cis women, minoritized groups, vulnerable populations, and they're not really in positions of authority. So reproductive care doesn't really matter.
If I could just come in, I just wanted to flag up an equivalent in maternity care, which I think is provision of maternal request caesarean section. So I think that's, again, an area where there's a lot of judgment about women wanting that. And I think a lot of women who do make that request are treated very badly by the system. So we did a campaign in 2018 where we wrote an FOI request to every trust in the country and analysed their responses. We found that only 26% of trusts were following the NICE guideline, which says that women making that request should have a discussion about the pros and cons and whether it's right for them. But if they still want it, they should be given it. And while individual doctors have the right to opt out of carrying out the caesarean, they should be referred to somebody who does. And it's still the #1 reason why women contact Birthrights, is women who want a caesarean and are not being listened to, or really feel that they're going to come up against a lot of resistance. And unfortunately, that is the case.
I believe that Sue E said something in the comments. Would you like to say something to everybody about this question?
Okay, I'm unmuted. Hi.
Right.
Okay, I was just trying to find something from the European Court of Human Rights about this, which would cheer people up a bit. But yes, I mean, in many of the, looking at it from the macro point of view, okay, in Parliament, in many other places, it's still put in a box, moral issues. Somehow this is a moral issue. Whether you have a new kidney isn't normally considered a moral issue, or indeed whether normally, for most people, whether a man has the snip isn't considered a moral issue. But you can see constantly in the court judgments and the commentators and the politicians, they're always treading this line. And obviously it's because they think there's a constituency to satisfy, that these issues go into moral boxes as opposed to care boxes and health boxes. But there's a lot going on at the international level and in the courts at various levels to attack this and to try and get, you know, women's views about all this, the sort of views that are being expressed here, accepted. So it's slightly cheerful, okay?
Thank you, Sue. I think Lucy wanted to come in on that point as well, and then maybe Paula as well. I don't know if you wanted to say something, but I thought it was an interesting point in the Polish context, because the campaigners in Poland have recently, as far as I've noticed, started to talk about abortion as healthcare on a bigger scale. So that's been a positive move.
Just from the perspective of Fumble, certainly we see working with young people that they have an enormous appetite for this peer-to-peer support and care for each other, and want to be part of this conversation and creating a sort of new vision of these conversations and culture around relationships and sex education and the associated topics within that umbrella. On the note of the theme of care, though, and relating a bit to what others have said just now, Fumble attracts a lot of young women and young non-binary people, primarily as our volunteers, and we have a real lack of young straight men keen to get involved, which is a problem for Fumble because young straight men are such an essential target audience for happy, healthy sex and relationships education. And I don't know why that is, but I assume it's to do with gender, and I assume it's to do with the fact that perhaps either young women or non-binary people are more aware of the need to provide this care or more motivated to do so because they've been disproportionately negatively impacted by not having received it. Or perhaps it's more of a fault of the barriers that put young straight cis men off engaging these conversations, and perhaps it's more of a shameful thing and masculinity is all tied up in it. So I guess that's a question of care too. And we see Fumble and sex ed as a societal duty of care to young people, particularly in the internet age. We feel like young people had been basically abandoned to the internet. And so Fumble was conceived as a sort of in response to the feeling of needing to care for young people and offer that sort of more healthy, engaging resource. And a final note on Care for Fumble, the reason we've registered as a charity now is because we started off as a genuinely quite diverse group of young people across sexualities, genders, and across ethnic minority backgrounds, as well as lots of white people. But people have been dropping off as volunteers because we can't keep relying on unpaid labor to do this care. It's just not sustainable, and we shouldn't be asking people to be doing this unpaid care work on top of all the other unpaid care work that people have to do. So if we're to be a truly diverse and representative organisation, which Fumble genuinely strives to do, then yeah, that's why we've become a charity and we're aiming to get funding in now. So if anybody's got any big bucks, send it to all of these organisations, and yeah, that would be great. Thanks.
Could I actually answer Lucy? Is that all right?
Go ahead.
Yeah. Yes. Well, I don't want to out him, but I am actually the mother of a 28-year-old cis man, and I know quite a lot of his friends. And I think the simple answer to your question is patriarchy. You know, that they do want. Well, some of them are unfortunately not very conscious of, you know, these issues because they haven't got a feminist mother. But they just feel embarrassed, and they feel they ought to be trying to be real men. And I totally agree with you. I think there's an important job of work to be done with any of the younger men that we come across to help them to, you know, to be able to support other young men. I mean, I think it was you, somebody mentioned the pornography issue, and that's clearly an issue for, you know, young men, very young men, and getting their education online. That seems to be making, you know, partner abuse has rocketed in the teenage cohort, and I think that's part of the reason. Okay.
Right. Does anybody else want to comment on that point before we move on to the next question?
I can add one thing when it comes to young men. In many surveys, like from many surveys, we know that young boys are excluded from sex education even within their families. So we know that mothers usually are people who talk more about these topics at home, but usually with their daughters. So we know that firstly, men who are fathers, they don't really engage in sex education, and also boys are left out because in their life there is no one big moment like the first period. So boys don't ever have the talk even once. So it really starts very early, and still there are many schools that separate genders when it comes to relationships and sex education, and it doesn't do any good because the knowledge is probably, like the curriculum is probably slightly different for the genders. And of course, what about non-binary and trans people? This is another issue. But again, like the system, the patriarchy kind of excludes young men. So yeah, they should be simplified. But later on, they don't want to engage.
Just to kind of add to that, I guess, you know, I just wanted to highlight that the experience, particularly for Black boys, can be quite distinct in terms of, especially in terms of working class Black boys. There's a huge amount of kind of hypersexualization that happens in terms of expectation that they are very sexual, and they're and toxic masculinity and bravado there, even when that's not necessarily what they want or where they're at. I think that it's a need that's not very well recognized, particularly when people are coming from homes where actually they don't talk about sex at all, because that's taboo and stigma, that actually it's expected that they know everything already and they're not allowed to declare that they don't know. So there's a lot to be said about making sex education specific and adapting it, I think, to different demographics, which we don't really have like the resources to do, a lot of us, because we're working for free often in this sector, but it's just something to be mindful of, and I know this goes for a lot of different groups as well, but it's a very challenging group that often don't have their needs met at all.
Thank you, Annabel. There's also a very quick question for you, just a request rather than a question, to share the papers on pelvic floor pain and how it's managed in different gender races. And
Yeah, so actually the example I was giving was very specific, because my supervisor's working on this, and I've seen her draft, so I might have to wait until it's published, but it's in relation really to ovarian torsion and testicular torsion, and how they're... Oh, torsion, so it's when the ovary twists on itself. So they flip, and it's just an acute incident. It can happen for no reason, and it can happen to the testicles also. And essentially, if you don't do a procedure to go in and untwist it, then it dies off quite quickly. And there's evidence that when people present with pelvic pain, they're managed a little bit differently. Usually testicular torsion has got a time limit of kind of managing it within 6 hours, and the same is not really true of ovarian torsion, and people are a bit more reluctant to go and kind of have a look. So when that comes out, I'll let you know, but there is quite a lot of readings around this. I advocate reading like Angela Saini's book in Inferior as well, about medical sexism.
Thank you for sharing. I think we have time for one more question. Esther, do you want to come in with your question?
Hello. Thank you, everybody. It just got me thinking about how the stigmatization of abortion and other reproductive services, about how women tackled that in America, for example, in the 60s with the story of Jane, the underground service. And I wondered if that kind of thing exists anywhere in the world now where it's still illegal, and if anyone knows about it, because I just thought it was so empowering for everyone involved, learning how to help each other, and that sort of lost knowledge. And this is kind of going off on a tangent a bit, and yet it's about something we lost. So yeah, relating to the patriarchy, I suppose. I don't know if anyone has an answer about that.
I do. So it hasn't been lost at all. It's just changed with the times. So first of all, I'm a Chicago girl. My mom went to high school with 2 of the Janes, which my mom died in '86, and I didn't know that she'd gone to high school with 2 of the Janes until many years later. So that's something. The Jane Collective was also very white and middle class, and I think that you will find the sisterhood looks very different these days, you know, sisters and sisters. And so now we have pills. And the whole reason we have early medical abortion pills is because a group of women in Brazil needed abortions, and a woman was in the chemist and saw a bottle of ulcer medication and it said may cause miscarriage, and she said, I'll have me some of this. And because of that, because of women telling women about an over-the-counter medication with no medical intervention whatsoever, the maternal mortality rate from unsafe abortion in Brazil went down by 90%. And that is why France was like, oh, if we put this with mifepristone, this highly regulated drug, it becomes 99% or 97 to 99% or whatever the stats are, effective. So you have groups like Women Help Women and Women on Web, and other organizations that provide these medications to women in countries where abortion is against the law. If you go to the Women Help Women website, there's this brilliant, very long, but brilliant study about groups in Latin America who are holding each other's hands through second trimester self-administered medical abortion. And then you look at our friends in Poland, the Abortion Dream Team that goes around and teaches people how to do abortion with pills. The fact that Abortion Without Borders is here to help women from Poland, but women and pregnant people, but anybody under 14 weeks is strongly encouraged to use medicine. And we don't need to hold their hands anymore. We can do this on the phone. We can do this on email. We can do this on live chat. There's YouTube videos. You know, so whereas the Jane Collective was doing the old D&E, you know, scratching off the, you know, we have medication which isn't always quite as effective, but is certainly less dangerous. So the sisterhood is live and well, and we take all ages and genders and colors and sexualities, and it is. Like in America, they're fucking ready, right? Like Roe is already gone. Everybody's talking about, oh, Alabama, and it's like 80, you know, when I was in the States doing this work, 87% of US clinics didn't have an abortion provider. Now it's 90, 15 years later. It's anyway, yes. So I just wanted to let you know that it's happening. It's not been lost. It's just been upgraded.
Thank you. It's good to hear that you are able to refer people to these services as well, I suppose.
Oh, yeah. And we wouldn't at all know about, for instance, somebody in the Republic of Ireland who just misses the deadline for legal abortion in the Republic of Ireland, but needs a visa to travel elsewhere, and they're not going to get this visa. And we wouldn't at all be able to have somebody literally go hand them a packet of medication and a copy of the World Health Organization's protocol for how to take that medication in multiple languages.
Thank you.
Yeah.
Thank you so much, Mara and everyone. We're just coming up to 9, so I think we could continue talking for quite a long time. These are all very interesting subjects and great questions. Thank you for everyone who has been asking questions as well, and sending in links. We've had a lot of resources already, but if you do want to share any more, please do send them to us. Like I said before, we will be sharing them in a follow-up, and also putting them up in our resources section on the website. This is one of the things that we've been doing since the beginning of the lockdown, putting out more resources, online resources, because the library is obviously closed, and we haven't decided when to reopen yet, because even though everything is reopening, we don't feel it's safe and responsible for us to reopen. So we will probably not reopen for at least a couple of months, if not more. What else? In terms of follow-up, there will be more webinars, so do keep an eye out. We haven't quite set the date for the next one yet, but it's probably going to be in 2 or 3 weeks. So do keep an eye out. You can sign up to our newsletter to get it all straight into your inbox. That's on our website. You can also have a look at our other events on our events page. And finally, yes, remember to donate. I can see that the donate links are already going up, not just to the Feminist Library, but to all the organizations that have participated and spoken and are doing amazing work. And on that note, I'm going to unmute everyone so that we can give everyone a clap. And
thanks, everyone.
So again, thank you so much, everyone who's spoken and taken part. Yes, you can also clap with a reaction if you prefer to stay muted.
Thanks, Magda. Thank you, everyone.
Thanks, everyone.
Thank you.
Thank you, Feminist Library.
Thank you. Bye.
Thank you. Bye, everyone. Bye.
Thank you so much.